Dr. Murphy, if you have any additional questions.
Thank you, Mr. Chairman. Again, thank you guys for coming. Dr. Watkins, let me ask you a question just because we're looking at this in one level of the problems that you face with interconnectivity and challenges, by all means. My question is, what have you done in the state of Pennsylvania to talk to the other counties, because public health departments, at least in North Carolina, are run by counties? What have you guys done on a state level to develop interconnectivity? And I just, on a corollary, I did a lot of work in the North Carolina legislature with the opioid epidemic, and we had people on the border of North Carolina going into Virginia getting prescriptions, vice versa. So we worked close by with our state neighbors to develop a system that somebody in Virginia could know if somebody's jumping across the line and getting prescriptions in North Carolina. It's the same thing. It's state interconnectivity, not necessarily a federal push-down approach. When we look at the nation as a whole of pandemics that are going on, by all means we need to know that information. But these tend to be localized. And so what have you guys done on a state level to address this problem?
So let me just say that Pennsylvania is structured differently than North Carolina. I mean, we have 10 county and municipal jurisdictions. We're home rule, Commonwealth. So they are on our same system of disease surveillance, and so we are able to share that. So what happens are lab reports come in, or a report from a physician comes in to the state health office, and we push it to the jurisdiction. Or to the district office. Mostly if you're in a home rule system, if you're in Pittsburgh, for example, Pittsburgh's seeing their own records. But we do collect it all in the same data system. Philadelphia is large, and they're able to have their own and a different system. So we work with them. We work with them both from a disease perspective. We share outbreak information all the time. We work with them from an IT perspective to try to harmonize what we do. And of course, we're always working with our neighbors, whether it be on hepatitis A outbreaks or measles or sharing of, I mean, patients don't have borders. I mean, you can be hospitalized in New Jersey and go into a long-term care facility in Pennsylvania. Happens all the time. So we keep in touch, but we could do it better, faster, and without loss of information or misinformation if we were better electronically suited.
All right, well, let me just follow up then. Are you not electronically suited in these different counties, and why would you not appeal to your state rather than the federal government to make that happen?
So what I'm talking about is the sharing of laboratory information with disease surveillance, and that is happening at the state level, but it's not an easy connection. We've really not invested money in this in a long time. And for example, our immunization record is not connected to our disease surveillance record. And I'm speaking from the national perspective, CSTE. You've asked me a Pennsylvania question, but I could be answering for many states. I don't know if your immunization record in North Carolina is connected to your disease registry. For many states, it's not. So those are the kind of things that would help us get data and respond faster. You know, in a measles exposure situation, who's been immunized? You know, that's a hard question. It shouldn't be a hard question, but it is a hard question. And we've resorted to actually going to high schools, the old high school, who's stored records, who've looked them up for us because the physician had gone out of practice, or, you know, I mean, public health is a make it work kind of system, and we just do what we need to do, but we're getting further and further behind.
Let's see. Thank you. Thank you. And one other quick question, just with Dr. Robinson. In the success that we've seen with the cervical cancer vaccine, with the against the HPV virus, where, you know, here I am, a physician trying to put myself out of business. Where are we, and where do you see us as far as other malignancy vaccines? I'm going to give you prostate cancer, for example, because I've seen literature for that for 15 years. I just don't see the door being knocked down. So can you just speak to that briefly and what your experience is and thoughts?
Yes. 20 years ago, when I was in industry, we actually worked on a prostate cancer vaccine and a melanoma vaccines. What has driven the oncology vaccine has been supplanted by the monoclonal antibodies that have been developed with great success over the last 15 years. So that has somewhat moved the vaccine programs to, especially in companies, to a lesser degree. Some of those vaccines were extremely promising as we and others were evaluating those in the clinic, and I would suspect that once we reach the peak of the monoclonal antibodies for oncology purposes, that we will actually see a resurgence of vaccines for different types of cancer reappear probably in the next decade, in fact.
Thank you.
Great.